Good morning, everybody. I'm curious how this is going to work watching the previous speakers. Let's see. Wow, it's working smoothly. Okay. So far, we've heard some wonderful talks by Dr. Singhi as an overview of the general anatomy and physiology of the pancreas, and by Drs. Lee and Drs. Phillip about some of the benign aspects, overviews of pancreatic disease. And we're going to shift a little gears a little bit and talk a little bit more about the neoplastic nature of pancreatic disease. And I'm going to kick off by giving you an overview of pancreatic cysts in terms of where we're at. No relevant disclosures. So briefly, my outline is just a brief background about pancreatic cysts, and then we'll dive right into how we diagnose and how we manage them. So one might say that we are for those in clinical practice, there seems to be an epidemic of pancreatic cysts, and this has most likely been attributed to a detection bias in our clinical practice, and that our imaging resolution of CT and MRIs have become remarkably have evolved over the time and be able to detect smaller and smaller lesions. And we use CT and MRI as the backbone of clinical care in most situations of abdominal distress. And so perhaps it's no surprise then that as a consequence, we are detecting a lot of these cysts in the pancreas. There have been numerous different estimates. It's a real challenge to do a population-based estimate of the prevalence of pancreatic cysts to see how big of a problem this is. And there have been many methodological attempts to try to capture this. Many of them have been, and the reported prevalence has ranged anywhere from 1% to as high as 60%. And the AGA, the American Gastroenterological Association, did a very nice technical review in 2015, which actually systematically kind of described a list of the different descriptions. I would submit that as extensive as that work was, it also revealed the heterogeneity of the data out there and the different methodological quality, so making the confidence in the data somewhat challenging. My own bias or numbers that I like to use about in terms of reporting or describing the estimate of this condition are these two studies, one from Hopkins that used consecutive multi-detector CT scans in 2,800 patients in a mean age of 58-year-olds, excluding patients with known pancreatic disease or who had a CT4 abdominal symptoms concerning for pancreatic disease. And they reported a prevalence of about 2.6% with a median cyst size of 8.9 millimeters. In a very separate study done in Europe, which was an MRI-based study, and this was a study of a similar number of patients, 2,800, of healthy individuals who opted to participate in a kind of a whole health kind of examination where they got essentially elective MRIs. And these patients were generally asymptomatic and very similar mean age, similar male distribution, and a very similar cyst reported prevalence of 2.4% with a median size of 8 millimeters. Both studies seemed to see a general trend that the older you got, the higher the prevalence of these cysts, such that by the 8th decade of life, the estimated prevalence was about 10%. Now, since these studies have been published, it has been felt that when you look at the MRI-based studies of prevalence and the CT-based studies of prevalence, the MR studies tend to report higher prevalences. And it's probably because MR, because of its T2 signaling, is able to capture very minute cysts with higher sensitivity than CT scans. So it's probably no surprise that MR is going to report it at a higher prevalence, and it's probably the test that we are more commonly using as we discuss some of the algorithms. So why do we care about pancreatic cysts? Well, as you heard Dr. Singhi talk about, the primary precursor lesion for pancreas cancer is a microscopic lesion, and that's the Panin lesions. And you have various grades of dysplasia from 1 to 3 as it then becomes cancer. The two of the 3 recognized precursors, however, are macroscopic lesions, and specifically those are pancreatic cysts. Specifically the mucinous cystic neoplasm and the intraductal papillary mucinous neoplasm, both under microscope have evidence of pre-malignant cellular architecture with the potential to evolve into pancreas cancer. We don't have great estimates, but it's been discussed and described that perhaps about 15% of all pancreatic adenocarcinomas arise from these two recognized precursors, and the majority come from the microscopic pannins. Okay, so while there are over 20 plus described cysts in the pathological, histological dictionary, if you will, I'm going to really limit this focus, since this is an overview, to the three most common cystic neoplasms. And again, I'm excluding pseudocysts, which by definition isn't a primary cyst with an epithelial lining. And so these three primarily include serous cystic neoplasms, mucinous cystic neoplasms, and intraductal papillary mucinous neoplasms. So serous cystic neoplasms generally occur in elderly patients with a median presentation about in the 7th decade of life. Slight preference of females over males. Tends to present more in the distal pancreas, but not by much, and you can see these in the head. These are just some pictures here of serous cystic neoplasms. Here on the top, your top left, is an endoscopic ultrasound image of a classic microcystic serous cystic adenoma or neoplasm. You can see these microcystic kind of honeycombing kind of pattern. To the right, you'll see the H&E stain of glycogen-rich cuboidal cells. To your bottom left is a gross pathological specimen where you can often see stellate central calcifications in the center of the lesion. And then finally, a CT scan that correlates with this gross pathology. Mucinous cystic neoplasms tend to have a pretty strong demographic and clinical presentation in that it strongly favors women over men. Up to 95% of mucinous cystic neoplasms tend to occur in females. And they often occur in much younger patients, and typically in their 5th decade of life, with a very strong predominance in the distal pancreas. So this is one example where if it tends to be a female, tends to be younger, tends to be in the distal pancreas, and has certain features that I'll go into the next slide, you can almost be fairly certain that you're dealing with a mucinous cystic neoplasm, short of resection with histology. And here are similar images of what a classic mucinous cystic neoplasm might look like. So in the top left corner, you have what really appears to be a unilocular cyst. Perhaps it has 1 or 2 septae, but it doesn't really have that microcystic pattern that I just showed you. It tends to have a thicker wall, and it's fairly well defined, and you can see that on the CT scan in the top left corner. A gross pathological example would be in the bottom left, and then finally to your right is the histological description or pattern which is typically diagnosed by the presence of ovarian stroma underneath the columnar epithelium, and that is perhaps the key to making this diagnosis, which is then challenging short of surgery. Finally, intraductal papillary mucinous neoplasms, perhaps are the most common of these three primary cystic neoplasms, have a very similar presentation in demographics to serous cystic neoplasms. They tend to be in the elderly. There really isn't a predominance between females or males, and they actually can be a little more in the head, but they can be throughout, and they can be multifocal. So here's a nice cartoon or graphic of the two main phenotypes or types of IPMNs. One is the more common is the branch duct IPMN. Let's see, this pointer works. So what you can see, essentially, as Dr. Singh had shown, a nice normal main pancreatic duct. There's no dilation. This is very normal appearance, but off and connected are these cluster of grape-appearancing cysts, which are the classic imaging hallmark that you can see here on CT scan. This is a large IPMN in the head of the pancreas. This is an example by endoscopic ultrasound and by MRCP of these side branch IPMNs. And then the other variant is the main duct variant, where the main duct is actually involved, and you can often see these papillary growths. You see a very markedly dilated main pancreatic duct in about 30 to 40% of cases if during an ERCP or with using a side viewing duodenoscope, you may see what has been referred by endoscopists as the fish mouth ampulla, seen here with the extrusion of a viscous thick mucin. And these are some classic kind of CT images as well as a gross pathology picture. So the frequency of malignancy hasn't changed too much in terms of over time, in terms of what we think about this. But this report is limited by a certain bias in that this is based on those that have undergone resection. So these estimates might be a little bit on the high end. I think the take home here is serous cystic neoplasms are considered benign cysts with nil malignant potential. With that said, there have been some case reports describing serous cysts which have transformed. But for the most part, these are considered benign cysts with no malignant potential. Mucinous cystic neoplasms have an estimated malignancy at the time of resection of 15%. I think the key take home here for you is that main duct IPMNs, at the time of resection have perhaps the highest level of in situ carcinoma or high-grade dysplasia. So that will inform some of the guidelines as we talk about management. And then branch duct disease is about 24%. Again, this might be a slight overestimate due to the surgical bias in reporting. Okay. So I'm going to, with that background in mind, I'm going to segue into kind of somewhat of the history of the diagnosis and management of these cysts. So I think one might characterize the initial management of these cysts in the 90s as somewhat, perhaps for the lack of a better term, heterogeneous, because it was felt that there was a lot of variability in how these should be managed. Knowing how recalcitrant pancreas cancer can be, and knowing that these cysts are precancerous, there was a lot of perhaps enthusiasm that this may represent an opportunity to bend the mortality curve on pancreas cancer, and there was a lot of enthusiasm for surgical resection with the hope of cure. However, it was quickly observed that many of these cysts that were removed didn't actually harbor cancer and had very low-grade dysplasia, with a question of how quickly would these cysts have truly transformed into cancer. And keeping in mind the estimated mortality risk of pancreas cancer is around 2% with a morbidity rate of 30%, it started to become clear that perhaps in our enthusiasm to try to bend this curve, we were perhaps hurting people more than helping them with the diagnosis of these cysts. So in the early 2000s, there was with the limited evidence available, began a process of developing consensus about how we should manage these and to promulgate these ideas so that there'd be better standardization across the world on managing these cysts. And the first well-known were the Sendai Guidelines, which were done in 2004 and published in 2006. And I guess I'm kind of talking history now because these have evolved, but I'm doing so just so that you can understand kind of where we came from to where we are now. True to what I was saying earlier, serous cystic neoplasms basically have no malignant potential. The general recommendation is to resure with no follow-up unless the patient develops symptoms. Serous cystic neoplasms can be resected, particularly if they cause symptoms due to growth in size, but not because they necessarily have cancer. Mucinous cystic neoplasms, the general recommendation is to resect, and that recommendation has still been, for the most part, the case, not because of the imminent risk of cancer, but some of the practical aspects that these are, again, younger females with a distal lesion. Technically speaking, a pancreatic resection in that region is a little bit simpler, and the idea of following these patients for 30, 40 years with surveillance seemed to be a little bit taxing. And I think for those aspects, not necessarily the true biological progression of MCNs, the recommendation was to proceed with resection upon diagnosis. Finally, with main ducts, it was recommended for resection due to the high prevalence of cancer at the time of diagnosis. Whereas with branch ducts, because these were smaller and had a less malignant risk, there was recommendations to observe and resect. And they then recommended an algorithm here of how to do so, basically by size, by the presence of intracystic mural nodules, by the presence of whether the cyst was involving the main duct, either through involvement of the main duct of an IPMN biologically versus obstruction by a branch duct that was growing in size. And basically, this was the original algorithm. I won't go into detail, just to know that it existed, and this is kind of what was somewhat practiced from, I would say, 2006 onwards to about 2012. Meanwhile, the clinician's consciousness of these cysts continued to grow. And several different groups, and this is just a very limited sampling, began to evaluate the performance of these guidelines. And the general take-home was these guidelines were very sensitive for detecting cancer, but not very specific. So while it did improve standardization of practice, we were still operating perhaps on too many people who didn't need an operation. So with that in mind, and with the lessons learned, the international the group reformed in 2012 and added additional members with the intent to modify the guidelines to essentially move more towards a practice of active surveillance and less operations. Again, the idea to resect less and survey more. And so the major changes that they adopted were to abandon the size criteria. The previous threshold was 3 centimeters, but there's nearly nothing magical or biologic about 3 centimeters. The general trend is the larger the cyst, the higher the probability that cancer could be developing. They had picked 3 as a binary function, but the reality is you could have a 3.1 or 3.5, and that didn't necessarily increase your risk. So they abandoned that. They abandoned it as a criteria for immediate resection. Nevertheless, it was a worrisome feature that needed to be followed closely. They distinguished the fact that not all mural nodules were actually representative of tissue growth. Some were actually mucus balls that were then mistakenly identified as tissue growths. And then, similar to the size criteria of a branch duct cyst, the size of the main duct and its dilation, there was, again, nothing magical about greater than 5 or greater than 6, so they extended that to 10 millimeters. They also became a little bit more precise about their wording. They used to say symptomatic, but they tried to define that more because subjectively clinicians would interpret symptomatic as IBS symptoms, perhaps. And so, similar to form, the more you know, the less you know, the more complicated the algorithms become. And so compared to that last table that I showed you, now this was the revised version where you essentially had a higher criteria, 3 less criteria that would warrant immediate resection and surgically and good surgical candidates, a new group of features that were considered worrisome but not one that mandated surgical resection, and again setting up a system of a more sophisticated algorithm of surveillance, and then arbitrarily by different size criteria. I think the key aspects here is as you got into 2 centimeters or greater and you had a surgical candidate, you were doing a lot more intensive surveillance. So then the practical question was, at one point, would you consider surgery? And then the other issue that's important to note is that data didn't exist in terms of how long were we going to do this. And this became an obvious point because when you start recommending MRIs every year or every 2 years indefinitely in a health-conscious cost environment that we are in, you can imagine some of the new questions that would arise. So in 2015, about 3 years after that publication, the American, with the increasing recognition that these cysts were a more common problem, many of the American societies got involved and started to publish in response to their members' needs, started to do their own diligence to come up and craft guidelines and recommendations to help their physicians manage these using the best available data. And the American Gastroenterological Association came out with these guidelines, which had many similarities to the consensus guidelines because they were using a lot of the same data. They simplified it in that they focused on, they kept the 3 centimeter criteria, they kept main pancreatic duct involvement, and then the presence of intracystic nodules. I won't go into detail, but the main aspect here and the most controversial bit about these guidelines was the fact that they had recommended to stop surveillance if there was no significant growth after 5 years. And they kind of went on a limb and decided to kind of throw that out there. Perhaps not as much based on evidence, but perhaps to get the debate going about that we should focus on this and come to some kind of conclusion about what we really should be doing. And then since then, there have been several papers that have clearly shown that, after 5 years, nothing magical happens. It's not like the cyst resolves. There is a proportion anywhere from 5 to 10% who over, several years of following do go on to develop cancer. I think it's also important to emphasize the philosophical focus. And again, I'm importing my own bias into this, is that I think when the international consensus guidelines were being developed, they were really kind of focused on a patient-to-physician level of how do you manage your patient, Mrs. Smith, in your room individually and offer the best recommendations. Whereas I think the AGA were more influenced by how do you manage this as a population as opposed to just one patient. And how do you, and implicit in that is how do you then use your limited healthcare resources the best? And what would be the most cost-effective strategy? So on one hand, you could say the virtue of this approach is that perhaps we'll be doing less operations and using MRIs less, and perhaps from a utility perspective that may have the most utility, but inherent in this guideline is that they've accepted the fact that, yeah, they may lose some people to cancer, but that's acceptable because the overall net utility will be higher. So that's a philosophical difference in terms of how you emphasize your guidelines. Now, since then, there's just been a bandwagon of guidelines. The American College of Radiology revised their recent white paper, and this came out in 2017. The American College of Gastroenterology also came out with their own guidelines, which just came out in 2018. The ASGE also came out with theirs in 2016 or 17. The Europeans also had their own guidelines. So in an effort to try to standardize and come to consensus, and while there are a lot of similarities, you can imagine now there are differences, slight as they may be, among these guidelines, and one could argue whether we've created true consensus or whether we've now generated more chaos. But the ACR used their guidelines, and they invoked, what was different or unique about their guidelines is that they attempted to incorporate age into the management protocol. And again, I won't go into the specific details, but I think that's the main take-home point. And they also differed from the AGA in that they found a compromise. Rather than follow these indefinitely, they went beyond 5, but also started to suggest that maybe after 10, somewhat arbitrary, you could perhaps stop. So I'll go through that. This, again, is the American College of Gastroenterology algorithm, so I will go through that. So basically, the take-home here is there are numerous guidelines now, and you can almost, and then there are a lot of similarities among them, but there are some nuanced differences, and you just need to be aware of that as you talk about and think about this. Finally, in terms of diagnosis, and that pretty much covers the management aspect. The diagnosis bit also is inherent in that, and from the imaging, the clinical criteria. There's been a lot of interest in cyst fluid biomarkers, the idea being that what's secreted in the cyst would represent highly uniquely secreted proteins, DNA, metabolites, and these are relatively accessible by endoscopic ultrasound. I'm out of time. I'm going to be real quick, though. So cytology, which has historically been used, the limitation is that it's limited diagnostic yield. There just aren't a lot of cells in the fluid. For almost 2 decades now, close to 2 decades, we have been using cyst fluid CEA as the best potential marker to measure in the DNA, but it has a accuracy rate of about 80%, which varies. This table just shows that there are actually a lot of interest in different biomarkers now, which are ongoing. I would highlight DNA, which I think has come the farthest. There are different protein targets, cytokine profiles, microRNA, metabolites. And the holy grail here is not just to be able to distinguish the cyst type, are you dealing with a premalignant cyst, but could we identify a biomarker that's actually going to diagnose high-grade dysplasia so we can better select those patients who need an operation and would benefit from an operation. I mentioned DNA. Dr. Singhi's here. Hopkins and Pitt have done the most work in really moving this in a multi-center way in terms of better clarifying the role of DNA mutations, and they've had a few nice publications looking at a panel of DNA markers and kind of confirming that the presence of KRAS and GNAS essentially will diagnose a mucinous or an IPMNS. So I think we've moved the needle forward in our cyst biomarker work, and that we now, I think, are close. We have the tools to diagnose cyst type. Where we need to continue to work on is how do we find and refine panels and cyst biomarkers to define high-grade dysplasia. So I'll conclude at that. I think we have this, as I alluded to, a consensus or chaos kind of field right now. Because these are an increasingly common incidentaloma. A patient gets a cyst. They Google pancreatic cysts. They read about pancreas cancer. They're very anxious. There are multiple guidelines with the intent to help us, but because there are so many of them, that can potentially confuse things. But the general trends of time is that as we've become more comfortable with these cysts, we are doing a lot more active surveillance over resection. And I think the promise for this that hopefully will get us out of this morass is the value and promise of novel cyst fluid-based biomarkers. Thank you.